Hi, this is Linda McKinley. I'm going to be discussing my business plan for the implementation of an intensive case management program in CT surgery. The title of my project is called Intensive Case Management to Prevent Surgical Infections in Veterans with Social Deprivation, or the ISIS project. You can see a picture of the goddess of Isis, who was a goddess of protection and healing. A little bit about surgical site infections. There's about 16 million surgical procedures that are performed each year in the United States. About 2.5% of these patients will develop surgical site infections, resulting in approximately 300,000 infections each year. It is the second most common healthcare associated infection, accounting for 17% of all HAIs. Consequences of these infections include prolonged hospitalization. Sometimes patients have to be readmitted to the hospital or have additional surgeries. The mean cost per infection is $25,000, and there is significant mortality associated with these infections. We recently conducted a local case control study and found that social deprivation was strongly associated with surgical site infection in our patient population. Patients with a surgical site infection had 32 times the risk of a social deprivation factor than subjects without a surgical site infection. We do know that the VA cares for a disproportionate number of disadvantaged, low-income, and high-risk individuals. This project will improve surgical outcomes in this vulnerable patient population and meet the VA's vision of providing patient-centered, evidence-based care that is both an exemplar of excellence and value. The intervention is to optimize perioperative self-care behaviors. It's going to be a three-step process. The step one is to identify vulnerable patients with these social deprivation factors. Step two is to evaluate their self-care behaviors during the perioperative period. And the third step would be to optimize patients' ability to perform these self-care behaviors. The intervention is based on a hypothesis that there is a relationship between social deprivation and surgical site infection risk is somewhat mediated by deficiencies in self-care behaviors such as self-hygiene, tobacco cessation, wound care, and other behaviors during the perioperative period. The theoretical framework for this intervention is that social deprivation has been linked to poor health behaviors and outcomes. Self-care is defined as a real-world decision-making process in choice of health behaviors such as treatment adherence, symptom monitoring, and response to symptoms. Self-efficacy interventions have been found to be a strong determinant of behavior and have produced some of the most consistent results in behavior change, such as exercise, weight loss, and smoking cessation. Case managers will be used to optimize safe self-care behaviors during the perioperative period. And those tasks that would be important during this period would be symptom monitoring, nutrition, alcohol and drug restriction, smoking cessation, and other prevention behaviors such as hand washing and bathing. We conducted a market analysis for this intervention, and some of the internal strengths include that we have excellent clinical staff, that we already participate in surgical quality improvement programs, that we are a recognized organization in healthcare quality, and that we have an efficient electronic medical record that can facilitate this intervention. Some of the internal weaknesses is that we have a lack of continuity of care because of our academic setting and rotating physicians. We serve a very large geographical region, making it difficult for patients to come to our facility, and that some of the monitoring of our surgical quality indicators are flawed. For instance, when we monitor preoperative antibiotics, some antibiotics require a longer infusion period, but those quality indicators don't necessarily account for those nuances in that indicator. Some of the external opportunities for this intervention is that we have an increasing focus on health disparities in the VA, that there's a growing evidence on the transitional care models that are being implemented, and that we have a greater involvement with benchmarking and quality indicators. Some of the external threats are that there's decreased reimbursements for what they consider preventable events such as surgical site infections, that we have a growing vulnerable patient population, and that there is a lack of data collection for social risk factors. Our operational plan, it's going to be limited to one surgical subspecialty, and it's going to be administered within existing structures, so costs are going to be minimized. It will be at the Madison VA Hospital within the CT surgery department. The staffing includes the CT surgical nurse practitioner as well as the surgical subspecialty nurse case manager. We will be doing, during the operational period, reviewing of the screening tool for identifying patients with social deprivation factors, and also a development of self-efficacy evaluation scales to review specific tasks required for the perioperative period. Also developing templated progress notes for the electronic medical record, and sending the nurse case manager for health coaching training. The implementation plan, we have a pre-intervention and intervention period over a 12-month period of time. During the pre-intervention, we will be developing a multidisciplinary team, reviewing tools such as the screening tool and also the self-efficacy evaluation tools, developing the operational plan, the budget, and developing the templated notes for the electronic medical record. We will also be sending the nurse case manager for health coaching training. During the intervention period, patients will be enrolled. They will be first screened, then self-efficacy tasks will be evaluated, and then followed up during their postoperative course. Data will be collected during the postoperative period as well as, or during the intervention period, as well as program evaluation. The nurse practitioner will be conducting the preoperative assessment of deprivation, and anybody meeting the criteria would be then referred to the nurse case manager. The nurse case manager would be conducting the perioperative intervention of the self-care assessments and health coaching for the patient, which would include at least one pre-op visit, 1 to 2 hospital visits, and then a post-op phone calls, including an initial post-op phone call, as well as weekly until their post-op visit, where we would do the final patient feedback. The budget is based on return on investment model, where we'll be looking at the cost avoidance of the intervention. So we have approximately 125 CT surgical procedures that are performed each year, and that would result in about 3 to 6 cases that would have patients with social deprivation factors requiring intensive case management, and we hope to reduce infections at least by 1, which would be a savings of approximately $75,000. Surgical site infection treatment would be $25,000. If somebody needed to have additional surgery, that would be a savings of $50,000, and one rehospitalization would account for about $16,500. The cost of the intervention right now only would include the training, which was $5,000 for health coaching. No other costs would be incurred as the intervention is going to be incorporated into existing structure. So if you minus the cost of the intervention from the revenue through cost avoidance, it would be a total savings of $70,000. In conclusion, I believe that the intervention is patient-centered, results-driven through excellence and value of the intervention, and also forward-looking through evidence-based intervention, which is all aligned with the VA mission and vision. Thank you.